Today I'm Dr. Saumya Gupta, DNB second year from Asian Institute of Medical Sciences, Faridabad. I'm going to present the case of a 38-year-old female named Mrs. Razia. She's a resident of Shadabad and a homemaker. The patient presented to us with chief complaints of fever and weight loss since past 2 months, frothy urine since past 1 month, and swelling all over the body in last 15 days. The history is given by the patient as seems to be reliable. According to the patient, she started developing fever about 2 months back, which was usually low grade and intermittent. There was no diurnal variation, and it usually used to get relieved by taking a tablet of paracetamol. The temperature was not routinely recorded. However, on 2 or 3 occasions, the patient visited a local clinic and was told that she has a temperature of 100 or 101 degree Fahrenheit. It was associated with night sweats. However, there was no history of chills with rigors before fever, cough with sputum, burning micturition, increased frequency of micturition, pain in abdomen, vomiting, or yellowish discoloration of eyes. However, the patient says that she noticed a small lump in the right side of the neck, which was not painful. It was accidentally detected. It was about the size of a grape. There was no discharge from the lump ever, and it has been of the same size since she first noticed. For her fever, the attendants told that he had given the patient a course of antibiotic of about 5 days, the name of which he does not remember. And he used to give paracetamol to the patient whenever the patient used to feel, they used to feel the patient has fever. Soon, with the development of fever, the patient also started experiencing loss of appetite and subsequently had weight loss, which was mainly observed by the family members and was evident by the loosening of her clothes. There was never an accurate weight measurement. After about 30 days of these complaints.
Saumya, if I can stop here and if you just go back. So there was a history of neck swelling, right?
Yes, sir.
So what other history will you take when someone says they have neck swelling? Otherwise, there is no discharge, it isn't painful and all of that. So that is just directly related to the swelling.
Yes, sir.
But what else would you like to ask?
Sir, we would like to ask about sore throat, or we would like to ask about difficulty in swallowing, because for the tonsillitis or the for the upper respiratory tract infections like pharyngitis or any tonsillitis or yes, or parotid.
This is an external lump, right?
Yes, sir. This is
not
external.
An internal
No,
symptom
sir.
of any sort. So with that extra, what enters your mind if someone says I have a lump in my
neck? Sir, if anyone just says about a lump, sir, it could be just a lipoma which a patient might have noticed, and it is of no significance. But because it was in the background of a fever, and she has almost noticed at the same time.
So what do you think about someone developing a lump in a background of fever?
Sir, it could have been a lymph node, sir. We would later get to know on the examination. But as far as the history is concerned,
What else can it be?
So it could be a cellular. So it could be a furuncle.
It could be a furuncle, but obviously the way you have.
Yes, sir.
The history is not just to a furuncle.
Yes, sir. It is not, sir.
What else?
Sir, sir, it could be.
Can it be an abscess? Can it be either a pyogenic abscess or a cold abscess, which is
it could be, yes, sir. It could be a cold abscess, not a pyogenic abscess, I would say, sir, because again, it was not painful. The temperature, according to the patient, it was accidentally, but it could be a cold abscess, sir.
Sure. Could it be a thyroid lump?
Sir, but actually, it was on the right side of the neck. Actually, she told it at the back side of the right side of the neck. So it was not centrally located, neither it was at the front of the neck. It was actually on the side of the neck. So that's why I would least keep it as a thyroid.
It's unlikely to be a thyroid lump.
Yes, sir.
That's fine.
Yes, sir.
What other organs are there which can give rise to a swelling?
Sir, it could be parotid, any parotid infection like infectious mononucleosis with parotitis that can lead to the local lymph node enlargement, sir.
So lymph node you have mentioned already, so which is
yes,
fine.
Sir.
So I agree.
Yes, sir.
Right. So these are a few things that. So the point is that you should think at least in your own head what are possible causes that can give rise to a lump there.
Yes, sir.
And these are the ones that you will think of.
Yes, sir.
All right.
So,
all right.
Shall I proceed, sir?
Please.
So after about 20 to 30 days of starting fever and the weight loss that she noticed, she started noticing froth in her urine. And according to state in the words of the patient, it was like a soap bubble formed when she used to mix with detergent with water. So it was something it like bubble forming like that whenever she used to pass urine. However, she does not give any history of passing dark colored urine or cola colored urine at any time during her illness. And soon after this frothy urine, she started noticing swelling, which was initially noticed around the eyes, which was more in the early morning hours. And then after 5 to 10 days, she started noticing swelling in both her legs, but it was mainly in the evening hours after a day's work. And the swelling used to subside after taking rest. But after 1 week, the swelling gradually progressed all over the body, and there was significant swelling in her legs up to mid of the shin. This was later associated with shortness of the breath, which was more on doing work, physical activities more than routine activities like climbing stairs, or brisk walking, or washing her clothes. However, she did not experience any shortness of breath while doing her daily routine activities, and the shortness of breath used to subside on taking rest or lying down. She never gives history of breathlessness in lying down position. And after about 10 to 15 days, that is about 1 week prior to the admission, the patient noticed a decrease in her urine output. There is no history of joint pain, rashes, irritation or redness of eyes, altered bowel habits, yellowish discoloration of eyes, photosensitivity, or blood transfusions in the recent past. For these above complaints and the worsening swelling of the body, along with the fever that was not responding to the paracetamol, the attendants finally took the patient to a local hospital where she was worked up for fever. The patient was told that her tests are negative for typhoid and malaria, but she has very low hemoglobin levels and her kidney is not functioning well. And for this, she was referred to a higher center. However, the attendants did not comply to the advice and kept the patient at home. But after about 7 days, the patient had significant decrease in the urine output, about less than 500 ml, and she became so weak that she was unable to get up from the bed, and also had 1 to 2 episodes of vomiting. It was at this point that the patient came to our hospital in the emergency department and was admitted. In the past history, the patient is a known case of hypothyroidism since past 3 years and is taking L-Troxin 25 microgram. There is no history of blood transfusion, tuberculosis in the past, or diabetes mellitus. There is no significant history of prolonged intake of NSAIDs or alternate medicines. There is no history of nocturia, hypertension, or renal dysfunction ever told in the past. There is no history of high-risk behavior. In the personal history, the patient is P4, L4 with no abortions. The last childbirth was 2.5 years back. All were full-term vaginal delivery conducted in a local hospital, and all the pregnancies were uneventful. Her menstruation cycles are fairly regular with cycle length of 28 to 30 days and duration of 4 to 5 days, normal flow, and dysmenorrhea present in 1 to 2 days, in the starting 1 to 2 days of the cycling. Among the family history, there is no significant family history of hypertension or diabetes. However, she gives a history of contact with a family member recently diagnosed with a pulmonary box.
All right. Yeah, go ahead with summarizing.
To summarize my case, this is a case of 30-year-old female with fever of unknown origin of last 2 months associated with constitutional symptoms, lump in neck, frothy urine, and a sarca with renal dysfunction.
Well, this is just a listing of the symptoms, but you need to analyze the symptoms and tell me what do you think.
Sir, sir, my provisional diagnosis on the
basis... No, I'm not asking you provisional diagnosis. I'm asking you, what do you think she has? How do you analyze her symptoms? What do you think happened?
I would think my first impression of the entire listing the entire symptoms would be that this patient has a chronic inflammatory condition or a chronic infection going on, which has now led to her renal symptoms, and or either she had an underlying renal dysfunction, and now that has come up because of the constitutional symptoms, and it has exacerbated by the chronic infection that he is having from past 2 months.
Why do you think she has pre-existing chronic disease?
Sir, for the fever, it could be because it's a fever of prolonged duration of 2 months with constitutional symptoms. I could think that it could be a tuberculosis because she also has a history of recent contact. Plus, it is but epidemiologically also tuberculosis is very common in India. So with such background, I would first keep the history.
Okay, so let's just look at that. How do you, so give me a differential diagnosis of someone presenting with fever of 3 months, low grade fever with weakness and loss of appetite, etc. What are the some loss of weight and so on? What are the various possible conditions that enter your mind?
Sir, among the common infections that we have in our country, first would be the tuberculosis, sir. That would be the first thing. Then, secondly, sir, it could be, sir, next. So among the infections, so I would take tuberculosis only. Then in the rare causes, we could have a malignancy like non-Hodgkin lymphoma presenting with constitutional symptoms, but that would be later, but that I would keep a lower down. And then, sir, I said it could be so it could be autoimmune disease, like it could be SLE, sir, presenting with a autoimmune etiology, anything that is causing fever for like 2 months and not being diagnosed along with the constitutional symptoms. And
yeah, look, I think you're getting there, but you're doing very hesitant in a hesitant manner because you haven't analyzed the case like this. So
actually,
I don't know if you have been in some of the previous classes that we have discussed. You need to approach this in a very systematic manner, right? What could be the possible etiologies? It could be infective.
Yes, sir. It
right?
could be autoimmune.
So one is that it can be, let's even broader, it can be an inflammatory condition.
Yes, sir.
Inflammatory condition can be infectious and it can be non-infectious inflammation.
Yes, sir.
Non-infectious inflammations are what you are saying, autoimmune diseases.
Yes, sir.
Right?
Rheumatoid arthritis,
Then
SLE.
it can be malignancy of some sort.
Yes, sir.
You know, then if you just look at it, so and this should be true for any symptom that you analyze, whether it is fever or it is weight loss or anything. So think of, say, is it congenital? It is not congenital. Is it genetic? It is unlikely to be genetic. Is it infective? We discussed a few conditions.
Yes, sir.
Right? Is it malignant? It can be malignant. Is it degenerative? It is unlikely to be degenerative. Yes, right? So these are the broad groups of conditions. Now you need to drill down. In inflammatory, infectious, non-infectious, both are possible.
Yes,
in infection, you said tuberculosis. Any other infection? Do you think tuberculosis is the only possible infection here?
Sir, no, sir, not only tuberculosis, sir. Sir, as the fever was low grade, but it could be infective endocarditis also. But because the fever range was low, sir, so I would.
Low grade fever is a typical feature of subacute bacterial endocarditis.
Yes, sir. It could be subbacterial.
Right. So it could be infective endocarditis. Yes, it could be any other occult visceral infection, right?
Yes, sir. Yes, it could be some pelvic inflammatory disease or any abscess.
Anywhere in the body, any occult sepsis, and there is a lump, and that lump could be related to some infection, whether it is tubercular or non-tubercular. So you have to keep that in mind. But there could be. So, Puneet, can you please mute everyone? Yeah, please mute everyone. Yeah. So you should also think of where were we? I lost my chain of thought. So we were talking about infections, right? So
yes,
occult sepsis. But you should also think of other types of infection. For example, fungal infections.
Yes.
Fungal infections can also present in a chronic manner. You should say consider that. And all of these conditions can later on give rise to renal manifestations that we have discussed, right? So you have to have all of these in the list of your differential diagnosis at this stage.
Yes, sir.
You have taken only history.
Yes.
And then you go to non-infective inflammatory conditions and SLE, all the other autoimmune diseases, right? Come to mind. So you have to keep all of those in the list of your differential diagnosis. Rheumatoid arthritis is unlikely because she doesn't give an history of joint pains.
Yes.
But SLE is certainly possible, right? Some other autoimmune conditions are also possible. Then in malignancies, what kind of malignancies can?
Sir, with this fever, I would first keep as non-Hodgkin lymphoma as my first TD in malignancies because it has constitutional symptoms.
Yeah,
with
NHL, both
Hodgkin.
Hodgkin.
Yes, sir, both Hodgkin and
lymphomas.
Yes,
Lymphomas can be, and then there are a number of malignancies that can present with pyrexia of unknown origin, right? Which include kidney cancer and many other cancers also. So you should keep them in the list of your differential diagnosis.
Yes, sir.
Then that is one thing. And then the second is this person's renal presentation.
Yes,
so
sir.
What is your interpretation of this person's renal presentation?
Sir, I would first keep the possibility of acute kidney injury, which could be secondary to infection and hypoperfusion.
What is the definition of acute kidney injury?
So it is the worsening of the renal functions or rise in the serum creatinine within days.
Yeah, so within a matter of days, typically 48 hours is the time frame.
Yes, sir.
Yeah. And this is not 48
2
hours,
months.
right?
Yes, sir.
Yeah, so this is longer than that. So it is not that typical AKI definition. So it is acute, but what term do we use for this?
The rapidly progressive renal failure, which has kept as the second, sir. But
that should be your first one, right? Because why do you keep it as second possibility?
Sir, this is because we don't know, sir, because the kidney function, the first time that she was told about the derangement in the kidney functions was when she presented to local hospital. That was only 7 days back, sir. So although the symptoms are there, but constitutional symptoms are there for 2 months and the renal symptoms are also there for 1 month, sir. But because the history of renal...
They are there for 1 month.
So, yes, sir, there's for 1 month.
So you are analyzing her clinical history, or not analyzing her laboratory reports, right?
So then I would keep rapidly progressive.
Correct. So according to history, she has history of some kidney related symptoms for around a month. And now she has been found to have significantly elevated serum creatinine. Which fits with the definition of rapidly progressive renal failure. So what, in your mind, what is the possible cause of this rapidly progressive renal failure from history?
Sir, from history, it could I would again keep autoimmune as the first cause of rapidly progressive.
Again, I'm not
lupus, sir. Sir, cause of RPGN.
Listen. Again, you have to be systematic. Always be systematic. So you have now a disease of the kidney, right?
Yes, sir.
So what kind of diseases can the kidney develop? It could be a glomerular disease, it could be a tubular disease, it could be interstitial disease, it could be obstructive, it could be vascular. So what do you think?
So I would keep it as a glomerular disease first because of the history of frothyuria that is there for 1 month, and that was quite significant, sir, followed by generalized edema. So I would keep glomerular pathology as first.
Yeah. So yeah, exactly. I agree with you that this patient presented with edema symptoms, and frothyuria is neither here nor there, but of course you can take it as you can use it as a positive argument. So those indicate what do they indicate? What kind of symptom do they indicate, or what kind of abnormality do they indicate?
So they they indicate a glomerular pathology, mostly a
leading to what?
Sir, leading to proteinuria,
and proteinuria, right? So proteinuria, then hypoproteinemia.
Yes, sir, and hypoalbuminemia.
Right? So that's a good way of looking at it. What are the other? So that is number one in terms of your list of causes of kidney failure in this patient. What are the other possible causes?
Sir, I could keep it as acute kidney injury superimposed on underlying nephrotic syndrome, sir. It might be that the patient, it was a nephrotic syndrome first, and now because of hypoperfusion and the vomiting and all, it has now presented
for that, a patient has to have severe nephrotic syndrome. You know,
sir, but
the patient should be severely edematous.
Sir, she was actually very edematous, sir. It was like there was a lot of third spacing.
That's possible.
Yes, sir.
But what else?
Sir, next I would. Next I could keep as a chronic inflammatory like tuberculosis with renal manifestation, or I could keep it as acute interstitial nephritis secondary to infection or antibiotics.
This patient is likely to have received multiple drugs in the last weeks, etc.
Yes, sir.
So AIN is definitely a possibility.
Yes, sir.
And tuberculosis, what do you think tuberculosis could have done?
Sir, tuberculosis also can cause acute interstitial nephritis, first thing. Plus, it can cause.
That's very rare, right? Acute.
I know, yes, sir.
Due to tuberculosis is Pretty much rare. I think people would have seen one case or zero cases. What is the typical renal manifestation of tuberculosis, or what are the renal manifestations of tuberculosis?
Sir, it could be
someone with
sir,
tuberculosis developing edema, developing proturia, and then showing worsening of kidney function.
Sir, it could be
okay, just tell me theoretically, you tell me what are the renal manifestations of TB?
Sir, sir, it usually presents with renal involvement usually presents with urinary sterile pyuria with
that is not well. You are right. I mean, so yes, it is because of involvement of urinary tract.
Yes, sir.
So
yes,
how can the kidneys get involved with TB?
Sir, again, sir.
Okay, out of
the secondary membranous. Sir, I had read it. Sir,
people are giving
secondary
chat. Amyloid, right?
Yes, sorry, sir, amyloid, sir. So actually, I wanted to say yes, amyloid can.
Yeah, I'm sure you know this. It's
yes, sir.
So one gets mental block sometimes. So amyloid is a possibility.
Yes,
then what? Sir. How else? Now we are asking a theoretical question. How else can tuberculosis involve the kidneys? What is putty kidney?
Sir, putty kidney, sir, is sir, it is sir, I had read it, sir. It is infections of the.
So when there is extensive caseating necrosis involving the kidneys, so the renal parenchyma gets destroyed, and so more or less what you have is a caseating mass. So this is called putty kidney. Typically, it is a small kidney which just has a caseating, material inside it. That's what is putty kidney. And then you can have, as you said, interstitial nephritis, right? And sometimes it can cause renal papillary necrosis, all of those sorts of things. So tuberculosis, if you have that, then you have to keep amyloid as a differential diagnosis.
Yes, sir.
Yes. All right. And then you had you also kept as the differentials your, Hodgkin's and non-Hodgkin's lymphoma.
Yes, sir.
Can they involve kidneys?
Yes, sir. They can either cause secondary membranous nephropathy or adult onset minimal chain disease. That is the way they can cause, or it could be direct infiltration of the lymphomas in the kidneys, sir. So they can affect two ways, sir.
Right. And rarely they can cause RPGN also.
RPGN.
Right. What else? You also then had a list of differentials which included autoimmune conditions.
Yes.
So how can the kidneys be involved in that?
Sir, my first again, I'm repeating, sir, that the first autoimmune condition that I would think in this scenario would be systemic lupus erythematosus. It's a young female with background of multi-system involvement with lymph nodes and.
What is the multi-system involvement here? Tell me, what is the multi-system?
Sir, actually, sir, here multi-system, I would say that there's a renal involvement, sir, and she was also told that she has low hemoglobin, so hematological involvement must be there, sir.
That could be because of kidney failure.
Yes, it could be because of kidney failure. Yes, sir. So that's also.
There is no
fever.
Yeah, so don't use these terms lightly. When you say multi-system, you have to be prepared to explain what systems are involved.
Yes.
But I think, making a diagnosis of SLE in a female who presents with fever and renal involvement is reasonable. I wouldn't.
Yes,
yeah, so I'm not saying that, but be careful what you say.
Sure.
Right. Any other condition that comes to mind in terms of autoimmune diseases?
Sir, it could be Sir.
Not many, right?
No, sir. Considering the age and the negative history that I have taken.
All right. Why don't you? How about systemic vasculitis?
Yes.
Small vessel vasculitis. Do you think that's possible?
Yes, sir. That is a possible thing, sir.
Right? Is
yes,
it?
Sir.
Not?
Yes, sir. Yes, sir. It is, sir.
Yeah. So some people are writing, many things, Sjogren, etc. Sjogren,
history.
I don't think so.
Yes, sir.
I don't think so. Sarcoid is possible, but sarcoid would not typically present with proteinuric illness.
Yes.
How does sarcoid involve the kidneys?
Sir, so sarcoid again can cause as interstitial nephritis, sir, and it could be one of the causes.
What
Plus
kind of interstitial nephritis?
So, acute interstitial nephritis.
No.
So,
anyone knows the answer can type it in the chat box or do a. I know people are doing quick Google searches, but it causes a granulomatous interstitial nephritis, right?
yes.
You get non-caseating granulomata,
Yes, sir.
and you can have lymph node enlargement in sarcoidosis as well. So someone says HIV, HCV, that's very unlikely. HIV doesn't present just like this. HCV
Yes.
also doesn't present with fever and weight
Yes,
loss.
sir.
Someone has written CIN. I don't know where does that come from. This patient has proteinuria. At least history-wise, there is frothy urine and there is
Yes.
anasarca. So that CIN is very unlikely unless CIN is something else, which I don't understand maybe. So these are a few possibilities from history, right?
Yes, sir.
Okay, please carry on. I know we have.
Yes, sir. So coming on to the physical examination, on presentation, the patient was conscious, alert, and oriented to time, place, and person. Her weight was 70 kgs with height of 165 centimeters, giving a BMI of 25.9 kg per meter.
This is weight with edema, right?
Yes, sir. This is weight with edema, sir. It's not the dry weight. Sir. We don't know the weight of the patient because she hasn't measured it.
So should you be calculating the BMI in this?
So actually, we shouldn't, sir, because this is not the dry weight of the patient.
So, but you have still gone ahead and done it, right? Because you didn't think.
So actually, I thought, sir, but I thought that if I won't write, then it would be like I haven't taken the measurements. So I thought of writing it.
You should say that you have given her weight, but you can say that I know her weight, I know her height, but I don't think we can use this information to calculate the true BMI.
Sorry, sir. Next time I'll take it.
Right. Great.
Yes, sir. The nutrition again could not be assessed nicely because there was edema, but seemed to be adequate. The patient was lying comfortably in supine position. Her pulse rate, she was tachycardic with pulse rate of 110 per minute, regular, normovolumic, synchronous. All peripheral pulses were palpable, no radial and radiofemoral delay. Her blood pressure was 100 by 60 millimeter mercury in right arm supine position. And on standing also, she had the same blood pressure measurement. She was little tachypneic with respiratory rate of 20 per minute. Respiratory system on inspection, it was bilaterally symmetrical with no intercostal recession, no supraclavicular fullness. On palpation, there was no lump, no raised temperature. Trachea was central. Percussion had dull note in bilateral lower lobes, and on auscultation, there was reduced air entry.
Sorry, just hold on. You're saying bilateral lower lobes. What is lower lobes?
Sir, lower zone, sir. So sorry, sir. Just
what is lower zone?
Sir.
Could you describe chest examination? Let's say you are auscultation.
Bilateral lower, sir, auscultation, sir, supraclavicular, infraclavicular, then sir.
So where did you find the dull note?
Sir, in the sir,
infrascapular regions?
Yes, sir, infrascapular regions, sir.
Right?
Yes, sir. Yes, sir.
Yeah, this is, I mean, you can get away with all of this, but it just means you don't think.
Sure, sir. Then auscultation, there was reduced.
Bilateral lower zones. What is lower zone? I don't.
So intrascapular.
Sometimes you write lower lobe. Sometimes you write lower zones.
Sorry, sir. It should be intrascapular area. There was reduced air entry in the intrascapular areas with creps present and normal vesicular sounds and other.
Where were the creps? And what was the character of the creps?
So it was bilateral expiratory creps.
Which area? Which part of the lung?
Sir, infrascapular, so bilaterally.
Where?
Sir, bilaterally infrascapular. Sir.
Infrascapular.
Yes, sir.
So be careful what you're saying, because you're saying there is dull note in the bilateral infrascapular.
Sir, in the mid-scapular region, sir.
Look, that's what I'm saying. You need to be careful what you say.
Yes, sir. Sorry, sir.
This is not Asian Institute where you can say whatever and no one will care.
Sorry, sir.
What is the meaning of dull node and crepes in the same region? What does that mean?
So it could be.
If you auscultate, you find a dull, you find crepes, and when you percuss, you find a dull node.
Done.
What is the interpretation of these combination of findings?
Consolidation.
Likely to be some sort of consolidation.
Consolidation.
Yeah. So that is why when you say this.
Yes, sir.
But here you are saying reduced air entry, so that doesn't
Yes,
indicate consolidation unless there is also concomitant pleural
effusion,
in which you can find bronchial breath sound at the upper level of the effusion. All right, please carry on.
So then in the cardiovascular system, the inspection, the precording was normal, apex was seen below and slightly left.
It's very unlikely that in 25.9 BMI that you have calculated, female, you were able to see the apex. I don't believe it.
Sir, actually, sir, I tried to see, sir. It was, and I had confirmed it on.
Very unlikely. We are not seeing the patient right now, but I can tell you it's very unlikely. In a female, multiparous female, you were able to see the apex. I doubt it, especially if she has edema. All right.
There was no murmur on abdominal inspection. The abdomen was not distended. There were no engorged veins. Umbilicus was central. On my palpation, sir, I found hepatomegaly, which it was 3 fingers below the costal margin, and the margins were the surface was smooth, the margins were rounded, and the consistency was firm. There was also splenomegaly. The spleen was palpable, sir. It was 2 fingers below the costal margin, and the borders were palpable and were in the axis towards the umbilicus. And on percussion, there was resonant note in all the quadrants, and there was no fluid thrill. On percussion, there was no shifting dullness, sir. CNS, the patient was conscious, oriented to time, place, and person. Power was 5/5 in all limbs, and there was no focal neurological deficit.
Okay. Examination over?
Yes, sir.
No lump?
Sorry, sir. So, I'm sorry, sir. I haven't completed, sir. So there was a pallor. The icterus was absent, clubbing absent, cyanosis absent. Lymphadenopathy was present, sir. There was a lymph node about 3 by 3 centimeters in the posterior cervical area, and it was firm, sir, and the surface was smooth, and it was non-tender. The temperature was not raised, and sir. There were multiple, no, sir, there were other surrounding small lymph nodes, sir, which was about the size of 0.5 centimeters surrounding this big lymph node, sir. And there were multiple inguinal lymph nodes, sir, which were present, and they were small in size, about 1 centimeter in diameter, sir.
You are making a diagnosis of, at least you have been,
yes,
so far you have been consistently pushing a diagnosis of tuberculosis. So yes, when you describe a tubercular lymph node, how do you describe it?
Sir, it is usually matted, sir. There's a firm matted. Yes, sir, and sir, the inguinal lymph nodes were matted, sir. But the ones in the cervical.
You didn't use the word matted, whether it was matted or not matted. You didn't say either way.
Sir, in the cervical area, there were non-matted lymph nodes, but in the inguinal area, the lymph nodes were matted.
So you have to say this, right?
Yes, sir. Actually, I made it in the presentation. I don't know. Sorry, sir.
All right.
So.
Okay, there is no spleen.
So spleen was also there, sir. So was hepatosplenomegaly. The liver was palpable 3 fingers below the costal margin, and the spleen was palpable about 2 fingers below the costal margin, sir.
All right. And
along with lymph nodes, sir.
There were no axillary nodes.
No, sir. There were no axillary nodes, sir. Just the posterior cervical, small multiple cervicals, and inguinal lymph nodes, which were matted.
All right. Okay. What about the fundus?
Hello.
Hello. Can you hear me?
Hello.
Yeah, can you hear me, Saumya? Saumya, can you hear me?
Hello, sir.
Yes, I can hear you, Saumya. Can you hear me? Hello.
Sir, your voice is audible, sir.
Looks like Saumya is not able to
Yes,
hear.
sir. Her connection seems to be a problem.
I can see her. Saumya, can you hear me? You're muted. Saumya,
Sir, am I audible now, sir?
yes, now I can hear you.
So there was some problem with the network, sir.
So I was asking you about the ocular fundus. Did you examine the fundus?
Yes, sir. I had examined the fundus, but there was no. So there was no hypertensive changes, or there was no macrotomy.
Okay. All right. Please carry on.
Okay, so now coming on to the investigation, sir. So the patient had bought some outside investigations, and which were about a week back, and it revealed a hemoglobin of 7 gram per dl with TLC of 6.4. Platelets were 1.75. The urea at that time was 120 with creatinine of 4.58, sodium 130, potassium 2.7. LFT showed normal liver functions, and LDH was 205. She had bought the ultrasound report with her, which showed in liver enlarged up to 16.6 centimeters with normal parenchyma, no intrahepatic.
No, I don't want to tell you ultrasound and all of that.
Okay, sorry, sir. So then in our hospital, sir, when she presented,
just stay there. With history and physical examination, what is your diagnosis?
Sir, I would now, sir, again, I would keep my diagnosis, sir, either as a rapidly progressive renal failure with underlying lupus nephritis as a cause.
No. As a part of this, did you do a urine examination?
Yes, sir. So the urine was, so urine showed a 3+ protein with no RBCs, and the
no RBCs.
No RBCs, sir. Just 3+ proteins, sir.
No other microscopic abnormalities?
No, sir. No cast, no crystals, sir, and no RBCs, just 3+ proteins, sir.
So just read the answer. Find out the answer to this question. How common is it to find no casts in a urine where you have 3+ proteinuria? Okay. I want you to find an answer to this question. Yes, and share with the group.
Okay, sir. Sure, sir.
All right.
Yes, sir.
How do you think casts form in the urine?
So they are because of the tubular. So the casts are formed because of the tubular epithelium that is shed off and then passed to the
tubular epithelium that is shed off. Does that happen?
So actually, sir. So the TAM phosphol proteins, these are the proteins that are made by the tubules and then pass to the tubules and they form the casts.
Just the TAM phosphol protein themselves?
No, sir. There could be red cell casts.
If there are red cells, there will be red cell casts.
Yes, sir.
But does it require only TAM phosphol protein or something else?
So Peter too.
So TAM phosphol proteins will generally dimerize, heterodimerize with other proteins that are in the urine.
So beta 2 micro.
In the presence of albuminuria or proteinuria, it is possible that there will be no casts in the urine. First of all, that's something that all of you should remember. So even if you want to fudge a urine report, never say there was no cast. Right? थोड़ी सी नकल में भी अकल चाहिए होती है. So if someone who knows urine examination, if you tell them that there were no casts in someone who has proteinuria, they will, even without having a look at the urine, they will know that you are fudging the report or you didn't.
So actually, that was the report.
Yeah, that was the report. So someone fudged the report, not you, but someone, and you also you also, since you didn't know that this is likely to be wrong, you believed it, right? So for that, you need to know first.
Yes, sir.
Right? And
Yes,
we
sir.
can talk about casts at a later date because we have about 20 minutes or so. So that is your diagnosis. What is your diagnosis
It's
of the
next,
basic disease this patient has?
sir. About the basic disease, sir. It is of glomerular pathology, sir.
So basic
And the
disease,
first is
basic
nephrotic
disease,
syndrome.
basic disease is likely. What was the first symptom? She had fever, right? So that is the
Yes,
basic
sir.
disease that she has, because
It's a
that's
chronic inflammatory.
so now that you are, if your history and physical examination are correct, which I have no reason not to believe, then with long-standing fever, matted lymph nodes, weight loss, splenomegaly, what do you think?
Sir, I would keep sir as non-Hodgkin lymphoma, sir, as the first because of hepatosplenomegaly fever. So hepatosplenomegaly fever.
So
Lymph node would point to Mycobacterium tuberculosis, sir, tuberculosis first.
yeah.
But then because I had hepatosplenomegaly, sir, the liver and spleen were both in loss.
Hepatosplenomegaly doesn't happen in tuberculosis?
Sir, it's less commoner than lymphoma, sir.
Right. Can
So
it happen? Can it not happen?
it can happen, sir. It can happen, but it is less likely to be found in tuberculosis.
Why are you saying this? I don't agree with this statement. Can you quote some figures as to what is why do you say it is less likely in
Sir,
any
no, sir.
given patient?
No, sir.
Given the fact that you yourself said tuberculosis is so common in India,
Yes,
this
sir.
patient has matted lymph nodes,
Yes,
which
sir.
are practically not found in any other condition, rarely in other cases like
Yes, sir.
actinomycosis and so on. And hepatosplenomegaly can very well be due to disseminated tuberculosis. This patient has the
Fever, yes, sir.
pulmonary crepitations. This patient possibly has pleural effusion.
Yes, sir. Sure.
I'm guessing from your history.
Yes, sir. Yes, sir.
So this is classical presentation of
Mycobacterium.
disseminated tuberculosis, right?
Yes, sir.
At least
Yes,
from
sir.
history and physical examination.
Sir, yes, sir. Seems to be.
Right. So I would keep that as the first, second, third possibility, right?
Yes, sir.
Everything else comes only after that.
Yes,
There
sir.
are other conditions also which are possible. For example, even histoplasmosis can have this presentation,
Yes.
right? And lymphomas can have this presentation, but they are much less likely.
Yes, sir.
Given the fact. So always mention the common diagnosis first.
Yes, sir.
And then she has presented with still rapidly progressive renal failure remains
Yes,
your
sir.
diagnosis.
Yes,
And
sir.
now in light of the background illness of tuberculosis, what do you think, and your urine finding, what do you think is the cause of the RPRF?
Sir, sir, cause of RPRF could be, sir,
We discussed this, right?
yes, sir. So amyloidosis, sir,
Amyloidosis
could be amyloidosis, sir. Yes, sir.
could be, yeah, tuberculosis related amyloidosis.
Yes, sir. Yes,
or it
sir.
is possible, like you said, that this patient developed a nephrotic state due to tuberculosis.
Yes, sir. Closest.
And then acute kidney injury.
Acute kidney injury.
Depending. So that's
Yes,
also possible.
That is my
case,
second differential, sir.
Yeah, in that case, the nephrotic syndrome is likely due to what?
Sir, it could be, sir, the nephrotic syndrome again could be because of this, sir, secondary membranous, so, or it could be because of
secondary membranous you can't say because tuberculosis
FHS.
doesn't give rise to membranous nephritis. It's not a known,
right? Yes, sir.
So it could be anything else. Then you have to postulate that it is likely unrelated if it is due to, because typically other glomerular diseases are not shown to be associated in tuberculosis, right? They can be associated with other differential diagnosis like lymphomas and all of that, where you can have minimal
secondary.
change.
Yes, sir. Yes, sir.
Okay. And then the third is, of course, as you said, our acute interstitial nephritis on top of, again, one
underlying.
Yeah. So I know you want to say CKD. So CKD is possible in anyone, right?
Yes,
you did say it right in the beginning that CKD with acute versus.
Sir. Yes, sir. I have just.
So, but don't make a diagnosis of CKD in someone who has only a 3-month history and so many other things going on. right?
Yes.
CKD is always a diagnosis that you make when you have some positive clue. Like if you did an ultrasound and found small kidneys, then you can make
Yes.
a diagnosis.
So actually that I have just kept to complete the list because it can always be possible. But otherwise my first differential has
Possible,
always
you know,
been, yes, sir.
then that doesn't mean, that means you are not analyzing the history. In this patient, what is what are the likely possibilities?
So in this patient though, I have kept RPRF as the first and acute kidney injury superimposed nephrotic syndrome as the second, sir. Right from the beginning, based
Well,
on
in the
history or
beginning,
AINs.
you didn't even use the word RPRF.
Sir, I did, sir. Sir, it was my second DD, sir. I had already kept it, sir.
All right, it doesn't matter. Please go ahead
Yes, sir.
with the investigation. So you show hemoglobin is 7,
So these were the
TLC is okay, the platelet counts are okay, creatinine is elevated, potassium is somewhat low, LFT is fine. What else?
So this was the outside investigation 7 days prior to the admission in our hospital. Then in our hospital, when the patient presented, she had a hemoglobin of 6.6 with TLC of 9.7. In the differential counts, we had more of polymorphs 86 and lymphocytes 11. Platelets were 2.03 with ESR of 90. The renal functions had deteriorated from that time, and this time on presentation, the urea was 141 and the creatinine has gone up from 4.5 to 10.
Doesn't matter, you know, 4.5 to 10. How
Okay,
does
sir.
it matter?
Okay, sir. So, see, but the LFT was still normal, sir.
Anyway, let's forget about the investigation. I don't want to even see the investigation.
Okay, sir.
So you can close the slides, okay?
Okay, sir.
Just tell me now this patient has presented. How will you investigate this patient?
Sir, sir, as I have kept the first possibility as a renal progressive, rapidly progressive renal failure.
Why don't you close your presentation? Stop sharing.
Sorry, sir. Okay, sir. Sir, first of all, because I have, sir. So no, sir, as my patient has presented with history of fever and I have a lymph node, so I would first like to go for a lymph node biopsy to see.
Lymph node biopsy comes later, right? You will do some other investigations,
okay,
which you have shown already, but I
yes,
think
sir.
you have to mention those investigations. So you will of course do the kidney function. You will do 24-hour urine protein. You want to quantify. You want to look at the serum albumin. Those are the investigations you want to look at. You know, calcium, phosphorus, uric acid.
Yes,
because you have a diagnosis of lymphoma also to consider.
Yes, sir.
Otherwise, there is no reason. And then you have, you know, you've done ESR and whatnot. So
yes,
those are the things. And then for lymph node, what did you say you will do?
So I will go for a lymph node biopsy, sir, because it's a peripheral.
Yeah, you'll do a lymph node FNAC or a biopsy, whatever is easily available. Yes. FNAC, if it is available, you will do an FNAC. Yes, and what will you will what special instruction will you give to the person who's doing lymph node FNAC? They must send it for mycobacterial
AFB staining, sir.
AFB staining, yes, and culture. Yes, you will want. Yes. So was this done in this patient?
Yes, sir, it was done, sir. The lymph node biopsy showed caseating granuloma and the AFB stain was positive. So it was the lymph node biopsy was given as.
Yeah, tuberculosis is confirmed in this case.
Yes, sir. Yes, sir.
Now, okay, so that's one point which is, you know, which is solved.
Yes, sir.
Now let's come to the kidney disease. So what will you do for the kidney disease? How will you investigate the kidney disease? So
first I would like to quantify the protein because I had 3+ on my dipstick. So on quantification, the spot urine PCR came out to be 15.45 and on 24-hour quantification,
so
it was
what are the caveats of doing a urinary quantification in someone who has a creatinine of 10?
Sir, because it's a low GFR, sir, so the proteinuria would also be underestimated, sir. So
right,
24 hours urinary protein.
So even if if the patient had heavy proteinuria to begin with, yes, if the GFR goes down because glomerulus is not filtering, the protein urea value will come down. Okay.
Yes, sir.
So that's important. So what are the conditions in which a person has persistent heavy proteinuria despite low eGFR?
Sir, so it could be, sir, persistent. So it could be plasma cell dysplasias, amyloids, or SLF. Yes.
ये तो गूगली हो गया ना. This is a difficult question. No one Awesome. So anyone knows the answer to this question? So someone says heavy proteinuria in tubular interstitial diseases.
So
Oh my
in
God.
tubular, it's less than 2 grams. So it is never a heavy proteinuria. It's mostly in the glomerular diseases.
Yeah. So
Yes,
that's
sir.
unlikely, right?
Yes,
So
sir.
someone says FSGS, so that's fine. In malignant FSGS, you can have it. Amyloidosis, yes, that's the right answer. Amyloidosis, you can have heavy proteinuria in the presence of low EGFR.
Yes,
And thirdly, you can have this in diabetic kidney disease. So
Yes.
proteinuria remains high even when the GFR goes down.
Post.
So there are a few differential diagnoses here. And given the fact that you had already considered amyloid,
Yes,
I
sir.
think the presence of high UPCR also
Yes.
seems to push you in that direction.
Yes, sir.
Right?
Amyloidosis.
What
Yes,
other investigations will you do?
Sir, I would go for the serum albumin levels because of the persistent proteinuria.
What is the serum albumin?
So that's 1.1, sir, with hypoproteinemia, protein 4.3.
Okay.
Yes, sir. And then I would like to go for the other markers of chronic kidney disease like calcium, phosphorus, and
Why are you going on? What about the ultrasound? Will you not do ultrasound?
Ultrasound, yes, sir. I'll do the ultrasound, sir. The ultrasound showed enlarged kidney, sir. Of the right kidney was 13.5 centimeter into 4.6 centimeters, and the left kidney was 14.4 centimeter into 4.3 centimeters, and the CMD was well maintained, sir. And there was no hydronephrosis. And
so that's large. And they didn't notice any focal lesions in the kidney.
No, sir. No, sir. No focal lesions were present.
There was no infiltration in the kidney.
No infiltration.
There is no
No,
hydronephrosis.
No, sir. No
So
hydronephrosis.
what is your interpretation of this ultrasound?
Sir, I said this only favors the clinical background of amyloidosis in this patient, sir, because
Right.
we already.
Why does
Also,
the kidney become large in amyloidosis?
So because of the infiltrates, amyloid deposits, sir. And also this ultrasound showed hepatomegaly and the splenomegaly, which we also found in the clinical examination, sir.
Sure, fine. So because there is possible infiltration of the kidney with amyloid deposits. Yes, amyloid. What is amyloid?
So amyloid is a beta-pleated protein, sir, which is normally
it's a protein.
Yes,
protein which is deposited in many tissues.
Yes,
and so in this case, amyloid could, if there is amyloid in the kidneys, it could be also deposited in other organs. So
yes, sir.
Some explanation for the hepatosplenomegaly can also be because of amyloid deposition.
Amyloid, right? Yes, sir.
And the blood pressure in this patient was how much, you said?
Low, sir. It was on the lower side, 100/60. So that also favors. So this also favors our diagnosis of amyloidosis, sir, because of the nervous system involvement.
Why does the blood pressure become low in amyloid?
So because of the less stimulation of the sympathetic. Sir, because of the central nervous system involvement, sir.
Central nervous system involvement, so blood pressure low हो जाता है.
It's a cardiomyopathy also, sir.
Cardiomyopathy. Does this patient have cardiomyopathy? Was
no,
the
sir.
elevated?
No, sir. It was not elevated.
You were able to see the apex very well in the fifth intercostal space, according to you.
Yes, sir. So autonomic nervous system.
No, autonomic nervous system is very, very unlikely. It is possible that, but that happens in special types of amyloid, which are not AL amyloid. There are other specific neuropathic amyloidosis that you need to read about. All right. Orthostatic hypotension का क्या मतलब होता है? Diastolic dysfunction doesn't lead to hypotension. So I'm surprised that none of you know this answer to this question. Have you heard of adrenal involvement? सुना है आप लोगों में से किसी ने? So amyloid typically, because it is infiltrating many organs, it can also infiltrate the adrenal glands. And so from adrenal gland, cortisol production goes down, which gives rise to hypotension. And so in such patients, cortisol production, but also aldosterone production might go down. So in these kind of patients, you may need to supplement with cortisol, supplement with fludrocortisone, and so on. All right. Okay. So what we have just 5-7 minutes. So what will you do next?
Sir,
anyone, it's a dictum typically that anyone who presents with You also had all the other, immunological conditions in your mind. Do you think
Yes,
you
sir.
still want to pursue them?
Yes, sir. I would like to.
Why do you want to pursue them?
Sir, sir, although we are very much heading towards the amyloidosis in the background of tuberculosis and all, but sir, according to the text, sir, mostly after a very long-standing, sir, chronic inflammatory disease, do we get amyloidosis, sir? And plus, sir, and the history in this patient was only of 2 months. She was not even a defaulter. There was no past history of any chronic inflammatory illness, sir. So, and plus, there was rapidly progressive renal dysfunction, sir. The
Yeah,
creatinine.
but then, if there is RPRF due to lupus,
Yes,
what
sir.
is the urine finding?
So that would be active sediments would be present, sir. There would be
Right.
RBCs,
So we don't
sir.
have it. Yeah.
Yes, sir. We don't have it, sir.
So
Yes, sir.
I wouldn't really push for doing aggressive. And if you do it, it's all right, but I wouldn't push it. So I would sort of abandon that approach of doing dsDNA and so on and so forth.
So that we didn't do, sir, but we definitely went ahead with the renal biopsy, sir.
Yeah. So, but I asked you a question. You said yes. I will do immunological workup.
No, so sorry, sir. I thought it was about the further test. Sir. No, we did not go with the immunological workup, sir.
Didn't go. No, I asked you a question. What will you do? And you said you will go ahead with immunological workup.
Sorry, sir. Sir, I misunderstood.
Yeah, kidney biopsy is the right approach. One,
Yes, sir.
one thing which you should always keep in mind in all people present with otherwise unexplained acute renal failure is a possibility of multiple myeloma, but that is much not operative in this patient because you have a number of other possible causes. So doing a kidney biopsy is the logical next step. So what was the kidney biopsy finding in this case?
Sir, the kidney. So should I read out the entire biopsy or just the important?
Yes, just read out. Never read the diagnosis.
So the multiple sections were stained with HNE, PAS, and silver methylamine. Empty and Congo red include the renal cortical parenchymal area containing up to 10 glomeruli. None were globally sclerosed or solidified. The glomeruli reveal irregular mesangial matrix expansion consequent to deposition of a material that exhibits tinctorial properties of amyloid. Pale eosinophilic appearance with HNE stain, negativity with PAS and silver methylamine stains. Congophilia and greenish bifringes noted in Congo red stained sections viewed at the polarized slide.
So there is amyloid.
Yes,
now,
so there is amyloid.
so let's say there is amyloid. What do you want to know now about the amyloid?
So what type of amyloid it is? So whether it's a AL type, AA type.
What is it? So was that done?
Yes, sir. It was done, sir. In this biopsy, we found that it was AA amyloidosis, which would be
amyloid. What else do you want to know? What else do you want to know?
Sir, we would like to know about the chronicity, sir. If we could, sir, if that was 30 to 40%, sir.
So there is what else do you want to know? You also want to know what are the components of the kidney that are infiltrated with amyloid, because amyloid can infiltrate all components of the
components,
especially vascular involvement. Someone
yes,
has written vessel. Yes, so you want to see whether there is any vascular involvement.
Yes, sir. The arteries and arterioles, they exhibited variably thickened walls showing deposition of the amyloid. So there was vascular involvement.
That's also important because that really reduces
renal function,
renal autoregulation.
Autoregulation, sir. Yes.
Because then if renal autoregulation is disturbed, then the chances of renal injury developing also go up, even if there is no structural disease. But in this case, there is plenty of structural disease as well.
Yes.
Right? So I think those, so if you do a proper analysis of a case, you will get a diagnosis very easily. And if my bet is that if you look for amyloid. So now let me ask you this question. Now I want you to tell me, how do you want to find out which organs are involved with amyloid?
Sir,
tell me a non-invasive test you can do to find out how extensive is the amyloid in this patient.
Sir, it's the sir.
Everyone who is writing their answers, they're wrong.
Sir, it's a
yeah, someone
yes, scintigraph is a SAP scintigraphy.
Right, so that is what you will do, and you will know which organs are involved, whether it is there in the liver, kidney, adrenals, heart, wherever it is, right? It's not available, I agree, but I'm asking you the question. Can't say that it's not available, so I won't I will not give that answer. Right. All right, so I do need to go now, but do you have any questions you want to ask, Saumya or anyone else?
Sir, just one question, sir. Why would a history of just 2 months lead to amyloidosis so quickly, sir?
Yeah, look, this is something we don't know. So yes, even though you are right that a typical description is long-standing tuberculosis,
yes, sir,
but we have seen many times that a short history of tuberculosis also can present with a patient with short history of TB can present with amyloid. It is possible that there was actually long-standing tuberculosis in this patient. The symptoms were ignored and whatnot. So someone asked the question, treatment approach to this case. Unfortunately, there is no specific treatment for amyloid. So you can't
just treat the underlying conditions.
You just treat the underlying condition and hope for the best. Will you do a transplant in this patient?
So we can do a transplant in this patient, sir, but then we would like to look at the serum amyloid A levels. If it is persistently high, sir, then there is chances of reoccurrence of amyloid in the graft kidney. However, if the SAA levels are less than 10, then we can go ahead. Means that means with the treatment of the chronic inflammatory condition, the production of the serum amyloid A proteins is going down. So in that case, we can go ahead. So we need to look at the levels.
Yeah. And one more investigation I would do, as I said, I would look for serum cortisol level in this patient. And if the cortisol levels are low, you will supplement this patient with steroids. You know? All right. Anything else? What types of dialysis are possible? What type of dialysis is not possible?
Sir,
everything is possible.
Right? Yes, sir. Everything is possible.
Everything is possible, but you have to be aware that this patient has low blood pressure, so you will need to be careful.
Yes.
Anti-tubercular treatment, you can give anything. You can give the standard anti-tubercular therapy. Of course, you'll have to adjust the dose for kidney function, especially at ethambutol dose. So the duration is pretty standard, 9 months. There is no reason to think of changing the duration of ATT in this case.
Yes.
All right. Any other question? Timing of steroids. What do you mean timing of steroids? If there is adrenal insufficiency, you treat as if there is adrenal insufficiency. You give the pretty standard supplementation as you would do. Yeah, with active. You are not giving pharmacological treatment of anything with high dose steroid. You're simply giving replacement dose steroids. So suppose this patient did not have adrenal insufficiency, they would have cortisol in their bloodstream, right? So yes, whether or not there is active TB, you have to give replacement steroids because not having replacement steroids, in fact, will reduce the likelihood of fighting infection. In fact, for some time, you may need to give even a relatively high dose because this patient has perhaps active inflammation at this stage. Okay.
Thank you, sir.
All right. Thank you.
Thank you so much, sir. The students are fortunate to have you today. Thank you.